First, I want to thank the organizer for giving me the possibility to talk here about protein glycation. And I can skip my introduction because we have said so much about protein glycation. Should I use it? Okay, maybe I have to use it. Okay, so I will talk about one mechanism on aging, and this is protein glycation. That is these advanced glycation end products, or AGEs. And these are the products of some Browning or Maillard reaction. And I can skip it, but I want to show you that everybody knows it, because from nutrition it's this browning part. Whenever you heat something, it gets brown, and when it's brown, you see these kind of products appear. So it is very easy. It is a non-enzymatic reaction, this AGE formation. It's a reaction that means we have amino acid side change which will react with carbohydrates, and it will make this Schiff base, this Amadori product, and at the end we have a lot of different kinds of AGEs, advanced glycation end products. So this reaction is only dependent on concentration, temperature, time, and some kind of oxidation which is needed there as well. So we have this non-enzymatic reaction, and these products of this reaction accumulate with age. So what I wanted to skip, what I skipped, because I've seen these both talks after me, but one talk after me, that this handled these chemical parts of the AGE reaction. So I skipped the chemical parts of my talk because this is by the other ones, done by the other one. So these AGEs accumulate with age, and we see some pathophysiological mechanisms like binding to the receptors like rage and inflammation, protein modifications, you have an inactivation of enzymes. All these show this protein cross-linking, which means also stiffening of the tissue. So some of these results I want to show you. These are the cell activation by these kind of products. So you induce, for example, activation of intracellular kinases like the ERK kinases or the P786 kinase. By these Maillard products, for example in epithelial cells. You induce the activation of transcription factors like the NF-kappa B, which is shown, for example, here in cardiac fibroblasts, using HE-modified proteins. And this is HE-BSA. Or at the end, you have the induction of cytokines like interleukin-6, which is an inflammatory cytokine. So this is done, for example, in monocytes. So we have this kind of activation of cells, starting with kinases, going to transcription factors, and at the end to release of cytokines. Okay. Another thing example is the modification of growth factors. For example, modification of PDGF, which is the most important growth factor for wound healing. So if you modify PDGF, the activity of this growth factor goes down. And we have seen that PDGF, which we can take from cells from patients with diabetes, is modified. And if we look at the activity of it, it goes down. Here, for example, we have an increased amount of PDGF, which is modified on the right and non-modified on the left part. And we look for the activation of kinases like the AKT or the ERK kinase. And if you measure these and look down to the concentration dependency, you see you can activate the kinase with low concentration if you have non-modified PDGF, and you take this modified PDGF, the activity goes down. So maybe this is one reason why wound healing is reduced at old age or if you have diabetes. The growth factors are modified maybe, and the activity goes down. Now I want to see, has this really a relevance for humans? So I go to now the human situation and show you some examples for these AGEs. So we measured the accumulation of AGEs in the skin using this device which measures the AGE-related skin fluorescence. And we measure, on the other hand, the pulse wave velocity. That means the velocity of the blood within the vessels, and the stiffer the vessels, the faster the blood flow. So this is a very easy possibility to analyze your vessels. And what you see here is the higher the skin fluorescence, the higher the velocity. That means the reduced elasticity of the skin and the higher stiffness of the vessels as well. So we have this nice correlation that accumulation of AGEs, what we see in the skin, may reflect something which is going on as well in the vessels. Does it have some functional outcome for the patients as well? So we ask the question, does HE-modified cardiac collagen has an impact on the post-operative outcome? So we just go now to the operation of patients, and we isolated collagen. So you can isolate collagen very easily if you start with pepsin digestion of tissue. So we take right auricles, that is the right atrium, a piece of the tissue we have from every patient. Then we have the collagenase fraction, and at the end you have this highly cross-linked extracellular matrix, which we then digest and look what's going on there. And this is the ICF, that is the insoluble collagen fraction, which cannot be isolated just by collagenase. And you see here that most of the collagen of all patients is in this fraction. That means most of the collagen we can isolate from patients, from the heart of patients, is not a soluble functional collagen, it's an insoluble cross-linked collagen. And most of the HE fluorescence, that means the modification of the collagen is indeed in this fraction. So we have a highly HE modified collagen, which is cross-linked. And now you can see this is really related with age. So this is this collagen fraction, which is cross-linked, and you see it's a very nice correlation that you see HE modification of this collagen and the correlation with age. So this is not so bad as a factor here. And now we look to the outcome. Does it have to do something with the outcome? And we have the odds ratio. That means we have an outcome which is a combined endpoint for cardiac, renal, pulmonary, liver, wound healing parameters. Whenever a patient has a problem with a post-operative with the heart and with the liver, you get some points, and then you look for the odds ratio. The most important factor which predicts the outcome of the patients is the modification of this fraction. So this is the odds ratio, better than the age, better than diabetes or renal function. So it is really a nice factor to predict. So it seems really to be not to be healthy to have too much of them. And in the cardiovascular system we know it's bad to have a lot of HEs. But life is not so easy. Looking to the lung tumor formation, that is something we do in our clinic as well. And I started with my first investigation in lung cancer. I come to this clinic and I say, okay, I want to see if HEs predict the outcome of lung cancer patient. HEs are bad, so the lung cancer patient has to die if you have a lot of these HEs. Unfortunately, it's vice versa. So we have these non-small cell lung cancer patients, and the patients with low amount of HEs in the plasma died first. So these are these patients here. You see low HE fluorescence, and they die. That is a survival curve, 100% survival and 20% survival. This is 5 years follow-up. And you see survival is much more better if you have a lot of HEs in the plasma. So this is not very healthy to have a low amount of HEs in the plasma if you are a lung cancer patient. It is healthy if you are a cardiovascular patient, but not a lung cancer patient. So we thought about what's the reason why. So we make this tumor spheroid model, so it is an in vitro model of tumor formation. And we look then for migration of tumor cells into this collagen, and we see that the number of migrated cells as well as the cell migration distance goes down if this collagen is modified, or if you take the collagen from an old rat tail. So we isolate our collagen from young and old rats. So this is a modification which is done in nature, or if we modify it by ourselves. Always it goes down. So HEs inhibit tumor growth. We first think we take these plasma from patients with low and high amount of HEs. We incubate these kind of cells and look what's about tumor growth. And you see here, this is a negative correlation. That means the more the HEs are in the plasma, the more we have HEs in the plasma, the less tumor growth we can see in this bronchial carcinoma model. The next thing is when we treat our own the serum by our own, and we make HE modified serum, and the growth goes down. So this is maybe very nicely, but it does not tell you if these are the HEs in the plasma. Maybe it's just correlating, it's not really clear. So what we have done there, we look for mice. So this is atomic nude mice. We injected their these tumor cells, and we let them eat an HE-rich diet. And this is, in our hand, bread crust. We take bread crust, we take the HEs from the bread crust, and give them the mice to eat. And what you see here, that is in the control group and the HE-modified group. That means the group which eat a lot of HEs. And the tumor size goes down. That is a number of tumors with low tumor size and large tumor size. And in the group which eat a lot of HEs, the tumor size goes down, which can you see here as well. Tumor weight, after some weeks, it goes down in this group. So eating a lot of HEs is healthy. And I was in Saale last year in this IHG meeting, and they told us, I have seen a lot of clinicians here, they say, oh, they are so totally disappointed. They gave their tumor patient a very healthy diet, and it does not do anything. And I say for myself, oh yeah, maybe you give not so healthy diet, it is a lot of HEs, maybe it works. So what I want to show you that HEs originate from a chemical reaction, accumulate with age, it induces tissue dysfunction, inflammation, it correlates with age diseases, but we have to think very carefully what is good or bad for HE. If you look at the cardiovascular system, accumulation of HEs is really bad, and the function of the heart goes down. That's true. I believe it's still not a refilling problem, not a diastolic problem, not only the connection between the electrical coupling problem. And the other thing is, HE may inhibit tumor growth, but we have only looked to lung cancer, nothing else. So I cannot say that this is good for other cancers as well, just lung cancer. So I want to thank the co-workers in our groups which were there, the clinicians which work together with us, the funding. This is the clinic we are working here. I'm sitting here. And at the end I want to show you this picture. If you look on longevity, maybe not everybody wants to live so long. Thank you so much. And I hope I still have time.
Very well said.
Yes.
So let's take maybe one question. Who wants?
Oh, I can talk longer than I have. Oh, again,
So
now
that we're getting closer to be able to treat lung cancer, for example, immunotherapeutically, you don't need to worry about ages having a negative effect. So how are we going to reduce the accumulation of ages in people?
So this is very hard to say. It's very hard to say how to reduce HEs in people. You can eat less HEs, but I'm not so sure that's really healthy. Because at the end, if you really, we do not know what we can do with diet. So it's very hard to say HEs in the diet are bad. We have seen from the nutrition side, it's more healthy. It depends on the reaction going on in our own body. And
So how can you interfere
so
pharmacologically,
I'm
for
not,
example?
I'm,
or
I'm not
something?
so sure. I'm not so sure that it's good to reduce
Yeah.
that we reduce the.
If you
amount.
could, how would you do it?
If you could, I would stop the reaction that I showed at the beginning. So we should try to stop this reaction that we make this after the shift base on the Amadori product. If we can modify between the Amadori product and the last, the HE, this will be the best thing to do.
Or are there ways of doing that?
I'm not so sure it's really, not really working things. No, but this is your talk. You can ask him the question.
Therapeutic target. Ah, sorry.
Okay.